Dementia care doesn't fall apart because families don't care. It falls apart because the system expects them to absorb the impossible. My hot take this week, this one's spicy. We're guilt-tripping families into becoming dementia caregivers. I said what I said. As a health and care system, we hand families an impossible situation with minimal education and then rebrand it as love and care. Families aren't struggling with dementia because they don't care. They're struggling because the system made care a moral obligation instead of a shared responsibility. Let's try and change that. This week, we're tackling our broken dementia care system and some harsh realities that we don't necessarily talk about enough. What are the IRL challenges that families are expected to manage quietly? Where does the system most often step back instead of stepping in? Why is it so hard to get a diagnosis? Or rather, why isn't care available before a formal diagnosis? Why are there just so many gaps in dementia care? To help tackle this topic, I'm joined by Rachel Wiley, the dementia queen.
Welcome to the Aging Together podcast. I'm your host, Dr. Pooja A, Patel, a double board certified occupational therapist and gerontologist with additional certifications in dementia and fall prevention. This season, we are unfiltered. In this podcast, I interview guests who are experts in their fields or caregivers who are sharing their lived experiences. Let's meet today's guest.
Rachel Wiley is an occupational therapist, educator, and founder of the Dementia Collaborative, where she provides evidence-based training and consulting to help clinicians and care partners better support people living with dementia. She is the creator of the Certified Dementia Clinician Program, the Dementia Squad Learning Community, and the Care Checklist for navigating consent and autonomy in dementia care. Rachel serves on the Advisory Council for the Dementia Society of America and is the membership chair for the Vermont Occupational Therapy Association. Through her teaching, writing, and advocacy, Rachel is passionate about translating research into practical, compassionate strategies that promote dignity, meaningful engagement, and person-centered care for individuals and families navigating dementia. Rachel, welcome back to the show.
Thank you so much for having me back, Pooja. I'm so excited to talk about this, and I love your hot take. I've got a few of my own, too.
I'm sure you do. You've been in the industry for a long time, and I know you've got your hot takes, so let's hear them.
All right, we'll just start with one. I'm sure more will come up as we chat, but my hot take is that memory care communities, at least those in the United States that I've seen, are not designed to support people living with dementia throughout the continuum of dementia. They're not designed to support somebody throughout their entire lifespan. And we can dig into what that means, or we can dig into your hot take, but so many thoughts.
I am curious. Let's start with that hot take. So why do you think memory care units are not built for the continuum?
Yeah, so this is probably like a multi-layered answer. But I'm going to start by thinking about end of life. We know that dementia is progressive, and that as dementia progresses, that individuals living with dementia will require more and more support. And that eventually leads to 24/7 hands-on support and care. And the majority of memory cares that I've had the experience with are not designed to increase the level of support provided to each individual resident to be one-on-one at any point in disease. Yes, a lot of them have different tiers where you can pay more for additional support as someone progresses, but ultimately, I have felt like the majority of the families I've worked with have been kind of forced into a position where they need to not only pay for the memory care every month, but also pay to hire one-on-one caregivers to bring into the memory care to really provide the level of care that is necessary for their family member living with dementia. Not only that, but not every memory care is equipped to handle or address some of the most common challenges associated with dementia. So again, I know this isn't every memory care, but I've had multiple memory cares that will just flat out reject or refuse to admit an individual living with dementia who has had some history of certain behavioral responses. And again, that to me does not equal memory care. It means we can support individuals living with dementia regardless of their symptom onset and what their symptoms look like. And we should be able to provide them with the appropriate level of support throughout the entire disease process, including end of life.
Do you find that, because in my experience, I feel like when they start nearing end of life, if they need more one-on-one support, they often end up transitioning to like a skilled nursing facility. And those are
That's an
definitely
interesting
not
question.
conducive, but it does offer that one-on-one support and medical oversight that they often need at end of life.
That is a great point, Pooja. I think, that is a possibility depending on their specific needs end of life. Truthfully, the majority of the clients I've worked with who are end of life do continue to reside in the memory care community. So most of them might not meet all of the qualifications to transition and get that coverage from a skilled nursing perspective. Or there's the possibility that we are looking into hospice services and bringing in hospice care. But I would argue that even with hospice services, like, yes, hospice is amazing and provides really necessary additional support, they still don't have the ability to provide that one-on-one support in addition to the memory care staff. So yes, I think especially end of life, like really end of life, we have maybe more options for additional care. I still think that often that there is that gap that's not totally fulfilled, and maybe even more important, not more importantly, but more clear in the care gap is like right before someone qualifies for maybe hospice or skilled nursing, when they do have increased needs. So maybe we're talking like late, moderate to severe dementia. They're not quite qualifying for hospice, they're not qualifying for skilled nursing, but they have substantial increased need for physical assistance and support for all of their ADLs to keep them meaningfully engaged so that we can reduce behavior. And it's just, again, it's not any one individual's fault. It's not any of the CNA's fault or memory care directors. They only have so much control. In my mind, it's a system failure that we have,
It's the systems.
Very
it's
limited.
Always the systems.
Yes. Exactly.
Yes.
We just don't have enough staff to support the needs of all these people. And then to your original point, that pressure gets put back on the family. Like, hey, how are you going to fill the gap? Because this isn't what our system's able to provide.
Right. I've heard multiple families who end up hiring a private caregiver to provide that one-on-one care to their loved one in a memory care unit or in a skilled nursing facility. So, I think there's this misunderstanding of like, oh, well, they're in a facility, they're fine, like they're going to get the care they need. And ideally, yes, that's true. However, the supply doesn't necessarily meet the demands of care. And so a lot of times families end up paying for out of pocket anyways, get that support. And that's where, sometimes, and maybe you might think differently in this, but like sometimes I'm like, well, then they might as well just stay in their own home, in their own familiar environment, if you're going to afford and get a primary caregiver anyways.
Yeah, I mean, this is such a tricky answer because I think my gut is to say yes. If we're paying for 24/7 care and a memory care, at that point, like, save yourself the base cost of memory care and support other needs. And I recognize there are some challenges to that, and like, okay, then who is managing if there's call outs? Is it the family member? Is it the agency? Is there a separate care manager involved? Like, who is managing all of the staff and the people? Are there other people that are residing in that home who are impacted by the 24/7 presence of other individuals? Are the family then responsible for doing all of the training of like, here are all of the specific individualized needs of this person living with dementia? At the end of the day, yes, for the person living with dementia, it's often best to keep them in their own familiar environment. But yeah, I think that there's some nuance to that. Or like, it even makes me think of a client I've worked with recently where, the 24/7 care plus the base cost of the independent living apartment, just that was not financially sustainable. So the discussion was to move to a memory care community with the fingers crossed hope that that was going to be a good solution, quickly realizing that like the staff, again, no staff's fault, but just didn't have the capacity to offer the support and care that this individual really needed. Now they're supplementing. Granted, they're not supplementing 24/7, so financially it's still not quite as big of a burden as the 24/7 care, but they are still paying the base cost of memory care plus, 4 to 6 hours a day of additional support, which is just incredibly frustrating.
Yeah, I'm sure. I mean, and like you said, it's not their fault. It's just that's just how the system is set up, right?
Yeah. Yeah, exactly.
All right. What's your next hot take?
My next hot take, maybe this one's not as hot, but on the topic of memory care communities, I have yet to find one, and this makes me sound like I'm really crapping on memory care communities. No shade. I know they're doing the best they can under the circumstances, but I have yet to find one that has what I would consider adequate communication with the family. How, like, sometimes there's zero systems in place. It's like, oh, well, we'll call you if anything comes up. Okay, but the family also has a right to have some sort of regular update about what's happening with their family member. Like, what kind of systems can we put in place to facilitate adequate and consistent communication between family care partners and staff? I think that's a big gap.
I think that that is a necessary piece at any facility across the continuum of care. So you saying that reminded me of so even in the hospital, right? Like not everyone has the privilege to have family at bedside, right? There's people have to work, people are out of state, and it often falls on the nurses to provide updates, but only if the family member calls first, right? So if the family member is calling and asking for an update, then the nurse is the one who's usually answering and providing that update. And I have spent the last entire decade of my career so far working with phenomenal nurses and hospital systems, and they are worked to skin and bones. They are on their feet all the time, trying to keep up with medications, trying to keep up with self-care needs, trying to keep up with communication with interdisciplinary teammates, like rounding, like all of this stuff, right? And then on top of that, to expect them to be the primary communicator with every single family member is, I think, such a chaotic ask. Mm-hmm. And then on top of that, a lot of families or caregivers, whoever is there, wants to talk to the doctor. And then they're spending time paging the doctor, seeing when they can come by. Like there's all this time that's spent around facilitating communication, which should be a norm and not a specialty, right?
Yes.
And so I've always considered there should be, if there isn't already, but I just have never seen it, but almost kind of like a medical translator who works in every single facility, and their entire job is to communicate with patients, families, and caregivers.
Yes.
Like they do it every single day, twice a day, right? They just they go from room to room, call up the family, tell them what's going on so far, tell them they'll call back at the end of the day with any additional updates, and just keep going. And in the meantime, if there's specific needs or asks or requests, then the nurse or the doctor can handle that. But I think it would significantly reduce the amount of miscommunication or poor communication that occurs.
And just overall, stress and worry, too, about our family members who are in these situations. I'm going to make this comparison, recognizing I'd like to be very thoughtful about, I do not want to imply individuals living with dementia are like children. And I'm going to use this just as a comparative example. But I think about my niece going to daycare every day. My sister and brother-in-law get consistent text updates throughout the day with pictures with what she ate, with how she's doing. If she has a rash, they get a picture. If she has a fever, they're called and, somebody lets them know, but also they get these app updates regularly. Again, I realize these are different populations and different circumstances, but why don't we have something in place that can't just consistently be giving these types of updates? And again, I think to your point, it also absolutely needs to be considered what kind of additional burden are we providing on the care partners who are doing this. So can there be other individuals, other employees whose sole purpose is to communicate this information to the families, or can we reduce the burden to the individuals providing care so that they have the capacity to do that type of communication if that's what they want to do?
Yeah.
Yeah. I think
and to your point about infantilizing, that comes up a lot in practice, right? We don't want to do that. That's not the goal here. But the goal is to identify the two most vulnerable populations in our world, children and elders, especially elders with cognitive impairment.
Yep.
And so when we look at the disparity in how we tend to children versus how we tend to our elders, especially our elders with cognitive impairment, you can see that difference, right?
Absolutely.
From an institutional standpoint, from a caregiver involvement standpoint, from a workplace policy standpoint, right? Parental leaves versus caregiver leaves. That's not a thing. I just made that up, right? Like, we don't have that. You end up taking a personal leave or you FMLA, but FMLA only applies in so many situations, right? And I've gone down a rabbit hole with that before where it's just like, we don't have systems. Again, we're talking about the systems here. Like, we don't have systems in place to support our elders in the same way in which we support our children.
Yep.
And I think that's a big part of all of this.
Absolutely. That's it. I think it's almost like an entire, I mean, we could talk about this on like an entire healthcare system level too, but it almost is like an entire system restructuring is needed. Like, I don't know how we got to the point where the expectations are that we have like just the minimum number of staff needed and that somehow we expect individuals who are often CNAs, who aren't usually given the opportunity or privilege to have a significant level of training, who, you know, I was just talking to somebody from the state yesterday and we were talking a bit about this, and she said, also consider like potentially if these individuals who are CNAs and providing care, what about their history with things like trauma? Maybe they didn't grow up with being necessarily incredibly like cared for or didn't have like compassionate communication modeled to them. And now we're putting so much pressure and expectation on them to be like this backbone of all of our dementia care by saying like, you need to be communicating perfectly every time you work with a resident living with dementia, and you have to be gentle and you have to be soft. Okay, but we have these wild demands. Like, you have to work with this number of residents, you have to do it this quickly, you need to do X, Y, and Z perfectly.
But you have to be patient, and you also have to not get upset because we're not human beings, right?
Yep. Don't raise your voice. Don't. And again, it's like, we can't possibly, dementia care isn't done in a vacuum. Like, we have to recognize in order to support people living with dementia the best that we can, it also means that we need to take care of our workforce. And if they're not being well trained, educated, cared for, and we're putting these wild expectations on them, then ultimately we're never going to get to ideal dementia care, if that makes any sense.
Yeah. I mean, it makes perfect sense to those of us who have worked in the systems and know what that looks like.
Yeah.
But I think it's really important for the general community to understand what this actually looks like on the inside, right? I think one of the key things I always bring up is my brother doesn't work in healthcare, and he's had his experiences with the health system. And he's always like, our health system is so bad. It's so poorly run. Why is it set up so poorly? And I'm like, you think it's bad as an outsider? Imagine those of us who work inside the system at large. Mm-hmm. It is much worse than you think it is when you get into it. Like, those consumers, which I hate that we even say consumers of healthcare. That is just ridiculous to say. But the consumers of healthcare in this country are not even seeing maybe half of how actually institutionally poor our healthcare system is designed.
Yeah, it's absolutely true. And it's frustrating on so many levels. Again, I could go on like 10 million different tangents with this, but I also, you know, from the perspective of having worked in more like, quote, traditional settings for large healthcare systems, and then having had my own small private practice, the frustration that I think so many of us feel who are in healthcare, of most of us went into healthcare because we want to help people. And when we have this, you know, disconnect between we want to provide the best level of care possible, and we have to work within the system in order to get paid for what we're doing. And those two just don't always work together. So even for my private practice, I would like to think that we offered the best quality service that we could within the confines that we were working with, but it also meant we did not make enough money to financially sustain the business. We could have done things differently and made more money, but we would have sacrificed, in my mind, we would have sacrificed quality in order to do that. And so, yeah, our whole system is not really designed for supporting our individuals who need it or the people who are providing that direct care.
Yeah, absolutely. I mean, we can talk about trying to be private practitioners in this system that doesn't support private practitioners, right? From insurance credentialing to getting paid for your services to marketing services, and then all the back end ways we could make money by sacrificing our integrity, which we won't, right? And a lot of us choose not to do that.
Yep.
And we can't really hate on the people who do because, again, it's not sustainable in any other way. And you and I both have experience with this. And so I think it's important for also people to understand that part of it of like, hey, the private practitioners that you see are working really, really hard and they're trying really hard not to compromise their integrity so that they can continue to serve you in a way that's appropriate and meaningful to you and not just as part of another number in the system of a big facility.
It's true.
Or a big clinic.
True. Yeah. And it does break my heart to see, I mean, obviously I'm in just the dementia world at the moment.
Yeah.
But when I see these, occupational therapy practitioners all over the country who have such a deep passion for this work and who are so skilled and so good at what they're doing in the dementia space, and so many of them either leave the field completely or have to pivot away from their private practice, from providing direct patient care because it's just not sustainable. But at the end of the day, it's also like, you go back to, yes, OTs aren't reimbursed very well through Medicare, especially this type of work in dementia care for a variety of reasons. But ultimately, we're likely saving the entire system a lot of money if people could access this type of care. Because if they had the support from an OT who specialized in behaviors and environment and could support families so that they didn't feel like they had no options and had to just transition to a nursing home, okay, that's actually like a saved dollar amount at the end of the day. But again, our system just isn't working that way right now.
Yeah. Talking about cost-saving measures, I want to talk about how hard it is for people to just even get a fucking diagnosis.
Jeez, yeah.
And the fact that we can't initiate services until someone has a diagnosis and how much that delay costs not just the family, but also the system financially.
So true.
For our audience that doesn't know this, it can take anywhere from, I think in Illinois right now, we have like a 4 to 6 month waiting list for a neuropsych exam. In order to get diagnosed, and that's short. Yeah, I think we were at like 6 to 8, and it's slowly gone down a little bit because we've thankfully had some more geriatric neuropsychiatry physicians come through. In order to get a formal diagnosis for dementia, whether it's a specific type of dementia or dementia unspecified, you have to get evaluated by a neuropsychiatrist. It's a full day exam. It's anywhere from like 4 to 8 hours, depending on which assessment you're doing. And you have to make an appointment for that assessment with a referral from your doctor. And once your doctor puts in that referral, it could take, those wait lists are insanely long because we don't have enough neuropsychiatrists in this country. And depending on what state you are in, you might not have any. So it takes incredibly long to get a diagnosis, even after that testing is done, for then to initiate potential therapies and services and whatever it might be, whether it's medications for symptom management, whether it's actual therapy like physical and occupational therapy or speech therapy, whether it's caregiver training, some sort of program that they can qualify for, like any of it. You can't do any of it. So in the meantime, while you're waiting for this test, you as a family are trying to figure out what the fuck to do.
Yeah.
You're on your own.
Yep. Really stuck. And that's it. I don't know, Pooja, this might be like a little different state by state. At least in Pennsylvania and in Vermont, where I am now, a primary care provider can technically provide a diagnosis of like dementia unspecified.
Sure.
Or a diagnosis in general. The hard part is to get clarity on what type of dementia that is. That's usually where neuropsych comes into play. Many primary care providers do not have the either confidence or feel like they have the skills to support them in making a diagnosis. So many of them will refer out before they'll kind of go near that. I do think there is a push. Again, I can speak specifically to Vermont, but I would hope nationwide, there is a push to better support primary care physicians to be more comfortable and confident in trying to make some of these diagnoses for the exact reason that you're saying. We do not have enough specialized providers to be able to facilitate all these diagnoses. I recognize, again, it goes back to like primary care physicians already have so much burden on them. Like, they are required to see so many patients in such a short period of time. Like, okay, here's 15 minutes to try to figure out if this individual has dementia. That's like unheard of. So I think, again, systems level challenges that aren't fixed overnight, but I'm hopeful that there is at least more awareness of dementia within the primary care space to facilitate more appropriate connection of services sooner. And there is some progress being made on, I mean, this is very niche, but in the Alzheimer's front, so that doesn't include all of the other types of dementias, but they are making progress in terms of like biomarker testing. And it's looking promising that we're going to see some benefits to the use of like blood testing. There's still some nuance there about like pros and cons of that, but that will potentially make at least some diagnosing easier from a PCP standpoint. But I agree with you. In the moment right now, we have all of these gaps, and there's so many families who are saying like, okay, I know there's something wrong, but I can't access any support in the meantime. This person doesn't have a diagnosis. I can't get services through the healthcare system initiated. So then they're trying to rely on like, doing their own digging and research, and that puts an extreme burden on families.
Yeah. You know who is specialized in this area and could offload that burden on PCPs? Us, working in primary care.
Right. Yes.
Like, and it is such a high wall to climb to try and get PCPs to see the value of having OT in their clinics.
Yeah.
There's all these concierge physician groups now, and they'll have PT on site, but they don't have OT on site. And I'm always like, what do you do for your OT? A big part of it is they just don't know what we do, which is more than half the problem. But the other part is like, they're just using OT for like hand injuries. And they're like, we just outsource them to OT. Like, we just refer out. I'm like, there's so much more we could be doing as far as like, after a certain age, or if there's some predisposing factors for cognitive decline or concerns related to chronic disease management, or, just there's so much that we could do in a primary care setting that would help not only offset the burden on these PCPs, but it would set up the patient and their family for success in the interim while they're waiting for additional workup. And it would potentially decrease the risk of additional costs to the care system due to unknown mistakes that result in injury or falls or medication mismanagement or just anything.
Absolutely. So much potential. And this might be something you and I might offline more about this particular thing, but I am working with one of the health systems here in Vermont, and they are potentially carving out a part-time position for me to embed me into primary care for this exact reason. So and that's because an administrator is also an occupational therapist.
I love that so much. We need more OT practitioners. In healthcare management.
Truth, but that's it. There's so much potential for what we could do embedded into primary care to offload that. We can do those functional cognitive assessments and be able to flag that for the physician and say like, hey, based on care partner report, the testing I'm seeing and clinical observation, I suggest you dig into some of these cognitive changes. We also know that so many people go undiagnosed for so long because of, again, they have those 15-minute visits with their physician annually. They come into their appointment. The physician might ask something like, do you have any concerns with your memory? And the person, if they have dementia, likely does not have any insight into the fact that they have memory challenges. And so they say, oh, no, I'm fine.
Or they're in the denial phase.
Yeah, or they're in denial. Yep, absolutely. And so the physician's like, okay, check, great. No concerns with your memory. And they have high comportment, like high social behavior. So in those 15 minutes, they're able to maintain great social skills. There's no reason in that moment for the physician to think like, oh, I need to dig into this. But if we were to do an actual cognitive test, it would likely reveal much more significant changes or challenges than what they're able to get from a quick 15-minute conversation.
Yeah, I was reading, I think it was a study, or maybe it was like a white paper, I can't remember, but there was something about physicians, if they call the family or get a caregiver report regarding cognitive or self-care changes, they are like infinitely more likely to flag a concern than just asking the patient themselves directly. Because yeah, I mean, and we see that all the time, right? The lack of insight, the lack of understanding, the lack of awareness, especially in those early stages when it's hard to know if it's like age related or if there's a true concern for dementia. When you ask someone, they're gonna be like, yeah, no, I'm fine, right? But then you ask the spouse or you ask the kids and they're like, no, it's a problem, like something's going on, right?
Absolutely. And then the nuance of being able to ask the family, but in a way where we're not asking directly in front of the person living with dementia, because that might be an incredibly challenging, like to have, you know, a couple in the exam room and you're asking the person living with dementia, or the patient, you know, we are asking them, do you have concerns with your memory? They say no. And then you turn to the spouse and say, do you have concerns with their memory? Depending on their relationship, that might not be comfortable for that spouse to be able to be honest in front. So having mechanisms in place so that that family member can be candid and provide, you know, really their true observation in a way that's not going to trigger the person with memory loss or create unnecessary dynamics within that relationship. We also have to be able to facilitate that as well, whether that's like, you know, the family making a phone call or like having them in potentially separate spaces or having the family member fill out a paper form if that's accessible to them that they hand to the physician, those types of things. But
I have heard of family members like calling ahead before an appointment and letting the physician know so they can like dig into it. But that also requires, I think, a certain level of what's the word I'm looking for? Like authority to do so. Yeah. Right? Yeah. Like, are you listed as a HIPAA contact? Are you listed as a primary contact? Are you listed as a family member in the system? I do think if you're just sharing a concern and you're not asking for more information, then there's no real concern there. But if you're going to start then trying to dig into what the physician found out afterwards, you're going to have some problems if you're not on their HIPAA list, right? And so I think that's also important for people to know and understand is like, make sure that your family member is on each other's lists of authority for inquiries and education long before something like this comes up, because what's going to end up happening, you've probably seen this too, but I've seen this where they get to a stage where they're in denial and now they don't want their family talking about anything with their doctors, and so then they don't want to add you to their list of accessibility, right, to records and stuff.
Absolutely. And again, that could be denial or it could be just the part of their brain that allows for insight into impairment is impacted by the disease.
Yeah.
So,
or it could be paranoia.
Capacity for insight, right? Or it could be paranoia. Yeah. And I will often say too, it triggers like a sense of loss of control. I think many of us could empathize with the idea of being told that we have cognitive impairment. There's fear involved in that. Like, what's going to be taken away from me? Am I going to lose my sense of independence? Am I going to be told I have to immediately stop driving or working or whatever it is? So it's scary. But I think to your point, having these things in place, also making it the norm, like go to doctor's appointments with someone else. Even without cognitive impairment, it can be hard to retain everything that you're hearing during an appointment. So making it part of the norm that you're always going with your partner or somebody else to an appointment could potentially alleviate some of that stress if that comes up. But I really like your point, Pooja, of make sure you're on each other's lists. And regardless, if you have concerns about a family member and you know that they are not thrilled about the idea of you coming with them to an appointment, being able to call and at least leave that information so that the physician knows ahead of time, even if they can't call you back and share any additional information, at least if they have your insight ahead of time, it could flag some things for them to do some additional testing.
Yeah.
So I think that would be helpful.
Definitely. Well, Rachel, I think we can talk forever on all of our different hot takes related to this stuff. We've both been in the space for a long time, and you've spent your entire career in this space. And, you know, I do have to ask, have you seen any change, any positive change in how dementia and dementia care is addressed from when you first started to now?
Honestly, yes, definitely. So let's see, I've been working as an occupational therapist in the dementia space since 2013. So it's been,
13 years.
13 years, which is wild to me. Definitely there's been positive change in that space. Of course, like I always wish for more significant change, but absolutely. I would say the awareness of dementia in general is greater. I would say there's more awareness by primary care in general. So again, always room for improvement, but we're getting there. And I would say the number, like the volume of resources available to care partners is also better, especially online resources. There is a wealth of information, whether it be amazing podcasts like yours or the volume of like support groups or educational opportunities online. There's just a lot more awareness. And again, I know it's a struggle for private practice, but I would say the volume of private practices that do specialize in dementia is also much greater. So those all give me hope for the future.
Yeah. And there's a lot more initiatives, I feel, that I've seen too, that are trying to educate and equip the community at large in being able to support the communities, right? So I know you're a part of it, but I've gotten in touch with our chapter here too. But Dementia Friends, Dementia Friendly is a huge national initiative to try and educate and equip our communities to be able to come across an individual with cognitive impairment or dementia and be able to support them appropriately in the community. So similar to how, like if you saw a kid by themselves on a street struggling with something, you would go help them, right? Mm-hmm. And so in a similar situation, if you identify, elders in general, but that's a whole nother conversation.
Yes.
If you see someone struggling, how do you approach them to help them and support them? I think that's really great.
Yeah. And I think, we even see it in like funding sources as well. Again, I'm going to keep saying it, but room for improvement. Yeah. However, we do see that things like Medicare has rolled out the GUIDE program. And while there's room for improvement there, and the funding in my mind is not nearly enough to support all of the initiatives that they want in GUIDE, the fact that there is an attempt to allocate specific funding for people living with dementia and their families is promising. We're also seeing certain states allocate funding specifically for this population. We're seeing more awareness of different types of dementia. There's more awareness about like Lewy body dementias. We're seeing more information come out about late, which is a type of dementia. So I think definitely promising. And again, in the Alzheimer's space, the fact that we have pharmacologic interventions like infusions now to treat people with early stage Alzheimer's, that we're seeing more biomarker testing, all of these things are really promising in this space and hopefully will continue to improve and then also impact people with all types of dementia. So all good things.
Yes, for sure. For those who want to learn more about just dementia in general, Rachel came on the show earlier in this podcast on season 2 or season 3, I think it was, to talk about just the basics of dementia, what it is, how it presents, and sort of what to do. And so you can tune into that for more information. And then as a community member, you can also become a dementia friend, and you can check them out at dementiafriends.com to learn more and see how you can educate yourself for that. Rachel, any other plugs before we wrap up?
I think those are the things that pop up off the top of my head. People are welcome to check out my website. I have some like free downloads and things. dementiacollaborative.com for some additional resources, more specific behavioral resources and things like that. But Pooja, thank you as always for having me on. It's always so good to chat with you, and I hope some of the listeners found this helpful.
Yes, thank you so much for coming on anytime I ask you to, and for sharing your wealth of
always.
Dementia knowledge. And those of you tuning in, thanks for tuning in.
Thanks. Bye.
Thank you for listening to the Aging Together podcast. If today's conversation helped you, please follow the show, share it with a friend, or leave a quick rating or review. Your support keeps this podcast free, ad light, and growing. Until next time, let's keep learning and aging together. Take care.